Welcome to the EPG Pathshala. Myself, Dr. Swati Dhruv from the Department of Foods and Nutrition, the Faculty of Family and Community Sciences, Maharaja Sayajirao University of Baroda. I am here to discuss today regarding the complications that arise during pregnancy and their dietary management. Now, we all are aware that pregnancy is a special condition during which our human body experiences various physiological changes. Now, it is considered to be one of the most vulnerable phase in a woman's life. Now, although pregnancy is a normal physiological condition for the female body, it is no doubt a stressful as well as during this condition the nutritional needs, they are increased in order to be able to meet the needs of pregnancy. Now, there are various physiological changes that take place in the body of a pregnant woman. These physiological changes are, for example, hematological changes take place, cardiovascular changes takes place, respiratory changes, urinary system changes, alimentary system changes, as well as along with this many changes take place in the metabolism as well. Now, these physiological changes that we are talking about, they take place during the pregnancy. They are also coupled with other factors which often result in what we term as pregnancy related complications. Now, there are various types of complications that occur during pregnancy. Now, some of the changes that develop during the gestation period also having implications to the diet would be discussed in this module. One of the complications occurring during pregnancy is nausea and vomiting. Now, nausea and vomiting during pregnancy is a very common problem. The cause of nausea during pregnancy has not been completely understood. However, it does appear to be linked to the production of the hormone HCG, that is human chondroitin gonadotrophin hormone. Now, this is commonly experienced, that is nausea and vomiting, during the first trimester of the pregnancy, which peaks at around 10 to 15 weeks and it subsides by the 20th week, or maximum it goes on till the 22nd week of pregnancy. Now, this may be occurring due to one of the following reasons, like for example, nervous disturbances, placental protein intoxication, deranged carbohydrate metabolism, or even alterations taking place in the gastric motility due to elevated progesterone levels. So, in this case of nausea and vomiting, the dietary regime that should be followed should be that small regular meals consisting of easily digestible foods such as carbohydrates, fruits and vegetables, they have better tolerance. So, ideally during this incidences of nausea and vomiting, fried and fat laden or spicy and strongly seasoned foods, they should be preferably avoided. And liquids should ideally be taken between the meals and should be avoided with the meals. Now, with a restriction also of caffeine containing beverages. So, this is regarding the nausea and vomiting complication during pregnancy. Coming to the second complication is that of hyperemesis gravidarum. Now, hyperemesis gravidarum or pernicious vomiting during pregnancy is a complication of pregnancy that affects the homeostasis, the electrolytes and also the kidney function, and this would have an adverse effect on the fetal consequences. Now, this condition is defined as uncontrolled vomiting which might require hospitalization severe dehydration would be present, muscle wasting, electrolyte imbalance, even ketonuria would be found, and weight loss of more than 5% of the body weight would be observed. Now, it has been seen that most of these patients also have hyponatremia, hypokalemia, and a low serum urea levels. Now, many women have some nausea or vomiting or morning sickness, particularly as we mentioned earlier during the first 3 months of pregnancy. Now, the cause of this nausea and vomiting during pregnancy has been believed to be rapidly rising blood levels of hormone HCG, as we mentioned, which is released by the placenta. However, hyperemesis gravidarum occurs when there is severe persistent nausea and vomiting during pregnancy. So, this is different from the morning sickness, and this is more extreme than morning sickness. Now, this can lead to weight loss and dehydration, as I mentioned, and may require intensive treatment. So, the treatment method for this includes a range of options, which includes maternal diet and lifestyle alterations, and also the need might also be there of administration of intravenous fluids, and even steroidal treatment might have to be given. Now, the modification of the amount and the size of the meals, that is regarding the dietary management if we are talking, the modification of the amount and the size of the meals that are consumed throughout the day may also help to relieve the symptoms. That is, having smaller amount of foods and fluids more often would help in preventing mild cases of nausea and vomiting from worsening. That means it would help to prevent the worsening of these symptoms. Now, the meals should also contain more of carbohydrate than fat and acid. And protein rich meals also decreases the symptoms. So, lighter snacks including nuts, dairy products and beans, etc. are often endorsed. Also, drinks that contain electrolytes and other supplements are advised in this condition. Now, if certain foods or food preparations which are triggering the nausea, then they should be avoided. Now, there is research which has shown that one food, like for example ginger, is one food that is used for the treatment of hyperemesis. Now, what happens is the gastrointestinal symptoms of motion sickness and hyperemesis are quite similar. Therefore, the root of ginger, that is Zingiber officinale, has been studied to treat hyperemesis. So, the effectiveness of ginger is thought to be dependent on its aromatic, carminative and absorbent characteristics, and it is thought to act on the gastrointestinal tract to increase motility, and its absorbent property may help in decreasing the stimuli to the chemoreceptor zone responses and the consequent nausea feedback. The third complication that is observed during pregnancy is that of heartburn. Now, heartburn, as we know, that is regurgitation of food in the stomach, which is owing to the enlargement of the uterus and relaxation of the esophageal sphincter, results in heartburn, or what we say is the feeling of fullness. Now, it is usually mild in symptoms and is pretty commonly found amongst pregnant women. Now, this may occur during any of the 3 trimesters of pregnancy, but it is found to be most common during the 5th month of gestation. And the dietary management of heartburn is that it can be managed by taking small frequent meals and eliminating the triggering agents, that is the triggering food components. And the common heartburn triggers have been found to include acidic foods such as citrus fruits and tomatoes, greasy or fried foods, spicy foods, chocolates, coffee and carbonated beverages as well as alcohol. Thirdly, in this case one should also be focusing on the fluid intake. That is, the intake of the fluid should be increased as they are less likely to cause problems in comparison to the solid foods. So, one should take liquids like one can consume shakes, lassi, etc., which are also found to be protein rich. Another thing is that antacids are also considered as another therapy for heartburn management. So, for the above mentioned reasons, periodic health checkups, they have been said to be mandatory for all pregnant women, wherein all the above mentioned issues, they can be managed basically with dietary counseling. So, now coming to the next complication that is commonly observed amongst pregnant women is that of constipation. Now, constipation, as we all know, is a state of infrequent bowel movement and or difficult defecation. Now, this occurs basically owing to the pressure of the enlarged uterus on the intestine, which may often be aggravated because of the inactivity of the expectant mother. Now, this may also be due to increase in bowel transit time because of increased progesterone levels and decreased motilin levels. And then in addition to this, there is also enhanced water absorption from the intestines. So, this condition of constipation can definitely be managed by liberal intake of fluids, that is, one is water, fruit juices, vegetable soups, etc., and also foods which are rich in cellulose or fiber, that is approximately 25 to 35 grams per day of fiber should be consumed per day. So, for this the consumption of whole grains, cereals, pulses, fruits, vegetables, etc., one should be indulging in. Another thing is that one should be indulging in regular whatever the tolerable physical activity or the physical exercise that the pregnant woman is able to undertake. Another important thing is that she should be having a sound sleep, and during this phase the use of artificial laxatives should be preferably avoided and is usually resorted to if the first line of therapy fails to deliver the results. So, without that, unless and until the first line fails to deliver the results, one should not be taking artificial laxatives. Coming to the other problem that is observed by the pregnant women is that of edema. Now, various factors, they contribute to the foot and ankle swelling during pregnancy. Water retention or swelling may be present during the third trimester, which is generally observed primarily in the lower extremities of the body. Now, as the uterus enlarges, it puts a lot of pressure on the veins that returns the fluid from the legs, that eventually results in edema. So, in case of edema, the dietary restriction of sodium usually is not advised. See, usually what one feels is that whenever there is any kind of edema, then you should be restricting sodium, but in this case usually sodium restriction is not advised. But if edema persists or it aggravates, let us say, then maybe there might be a need to do so. Otherwise, sodium restriction is not advised. Coming to the other complication of pregnancy is leg cramps. Now, leg cramps, as we know, They are the painful involuntary muscle contractions that typically affects the calf, the foot, or calf, foot, or both basically are common during pregnancy, and they often strike, or they are often striking at night during the second and the third trimesters. That is, during the second and the third trimesters, this is found to be more common. While the exact cause of these leg cramps during pregnancy again is not clear, however, a calcium phosphorus imbalance as a result of reduced serum calcium concentrations has been found to result in muscular cramps. So, non-phosphate calcium salt supplementation and magnesium supplementation helps to alleviate this problem. Coming to the other very common problem that is observed amongst the pregnant women is that of anemia. Now, anemia during pregnancy, it is found that it is one of the most frequent complications related to pregnancy. Now, the normal physiological changes that are taking place during pregnancy, they affect the hemoglobin levels, and there is a relative or absolute reduction in the hemoglobin concentration. The most common true anemias during pregnancy are iron deficiency anemia and folate deficiency megaloblastic anemia, which are more common in women who have inadequate diets and who are not receiving prenatal iron and folate supplements. Now, severe anemia may have adverse effects on the mother as well as the fetus. So, the dietary management of iron deficiency anemia, which is found to be very common amongst the pregnant women, suggests the inclusion of foods which are rich in iron, folic acid and ascorbic acid, that is vitamin C. Thus, one should be consuming foods which are rich in iron like meat, chicken, fish, eggs, which are, as we know, rich sources of heme iron, and we are aware that heme iron is the one which is more easily absorbed. Also, non-heme iron sources, that is sources like plant foods such as vegetables, cereals, pulses, etc., that is the dietary source of iron, which would be in case of people who are vegetarians. So, that would be the non-heme source of iron. And also dark green vegetables, etc., should also be consumed as a source of folic acid. Along with this, as we mentioned, foods rich in vitamin C such as citrus fruits and vegetables should be consumed in the diet, because it helps to improve, as we all are aware, the absorption of iron. Now, in addition to this, that is, in addition to whatever the dietary modifications that we are suggesting, the government of India also has in place the supplementation of iron folic acid, that is IFA, which begins during the second trimester, wherein daily 1 tablet per day is given for a period of 100 days during pregnancy. And the same dose for 100 days is followed again in postpartum period. Now, if anemia is diagnosed during pregnancy, then 2 tablets of 100 milligram of elemental iron along with 500 micrograms of folic acid is prescribed for the correction of the deficiency for at least 100 days. Now, once the normal hemoglobin levels are attained, then the pregnant woman can be shifted to the standard dosage for prevention of relapse of anemia. So, monthly hemoglobin levels are assessed in order to check the improvement in the hemoglobin levels. Now, if it is found that the hemoglobin level does not rise in spite of the administration of IFA, then these individuals or these pregnant women, they are to be referred to the higher facility care. Now, women whose hemoglobin levels are 8 milligrams per dl or less, then investigation should be done to diagnose the cause of anemia. If iron deficiency anemia is the cause found, then injectable IM, that is injectable IM iron therapy, that is parenteral iron, should be given. Now, for hemoglobin less than 5, immediate hospitalization needs to be done and blood transfusion should be done. That would be as per the doctor's advice. Also, the side effects of iron and folic acid supplementation often become the reason for discontinuation of the consumption of these tablets. Gastrointestinal disturbances, constipation, nausea and vomiting are the most common side effects that are associated with IFA supplementation, that is iron folic acid supplementation, when it is taken on an empty stomach or in cases of excess dosage. Hence, creating awareness about the possible side effects of iron and folic acid supplementation increases the compliance, and women should be counselled to consume iron and folic acid tablets along with meals to have better results, because iron and folic acid tablets will help in absorbing more iron from the diet also. So, awareness should be done regarding the factors enhancing and inhibiting the iron absorption also. Now, as we mentioned earlier, that foods rich in vitamin C, also the process of fermentation, this helps in iron absorption, whereas food items like tea, coffee or calcium rich foods, they inhibit the iron absorption. So, this was regarding iron deficiency anemia. Now, coming to the other complication, that is pregnancy-induced hypertension. Now, pregnancy-induced hypertension, or PIH as it is commonly called, was formerly called toxemia or preeclampsia, which is the condition that pregnant women develop. Now, hypertensive disorders of pregnancy, that is preeclampsia and eclampsia, gestational hypertension and chronic hypertension, they are important causes of morbidity, and these at times do lead to mortality also. So, this pregnancy-induced hypertension is defined by the systolic blood pressure of 140 mmHg or diastolic pressure of 90 mmHg or both. And this is further classified into 3 categories, that is mild, moderate and severe. So, the cutoffs for these categories are systolic blood pressure of 140 to 149 and a diastolic blood pressure of 90 to 99 mmHg for mild, and systolic blood pressure of between 150 to 159 mmHg and diastolic blood pressure of 100 to 109 mmHg in case of moderate, as well as the systolic blood pressure of greater than or equal to 160 mmHg and a diastolic pressure of greater than or equal to 110 mmHg in case of severe. Now, this is the pregnancy-induced hypertension is a syndrome that is characterized by hypertension, proteinuria, that is large amount of proteins in the urine, and edema, as well as convulsions or coma. Now, among the hypertensive disorders that complicates pregnancy, preeclampsia and eclampsia are major causes of maternal and perinatal mortality and morbidity. Now, the pathophysiology is less understood and there are no set prophylactic measures for these complications. So, the goal of treatment is to prevent significant cerebrovascular and cardiovascular events in the mother without definitely compromising the fetal well-being. So, the treatment strategies basically they fall into two general categories, that is the management of acute hypertensive syndromes of pregnancy such as preeclampsia or eclampsia, and the management of chronic hypertension. Now, while the definitive treatment for acute hypertensive syndromes of pregnancy is delivery, expectant management along with close observation may be appropriate in carefully selected patients, especially before 32 weeks of gestation. And women with chronic hypertension should ideally be evaluated prior to pregnancy with a focus on the presence of end organ damage, evidence of secondary causes of hypertension like renal artery stenosis which might occur, and counseling regarding the risks of preeclampsia and adverse fetal events. Now, with respect to the dietary management, as volume contraction is common in preeclampsia, salt restriction is not routinely recommended. However, bed rest is frequently advised and has been shown to lower blood pressure, promote diuresis and reduce premature labor. Along with this, calcium supplementation appears to be approximately, if calcium supplementation is given, it halves the risk of preeclampsia, that is, it helps to reduce the risk of preterm birth and reduces the occurrence of composite outcome, that is death or any kind of serious morbidities. Hence, women with lower calcium intake, they are recommended by the World Health Organization to take calcium supplements, and the dosage of the supplementation of calcium in this case is to the tune of 1.5 to 2 grams elemental calcium per day. This is for the prevention of preeclampsia. Now, coming to the other complication related to pregnancy is gestational diabetes mellitus, or what we commonly call GDM, that is gestational diabetes mellitus. Now, it is found that 5% of all pregnancies are complicated by gestational diabetes mellitus. Now, gestational diabetes mellitus, it increases both maternal and perinatal morbidity. Now, gestational diabetes basically is defined as a state of glucose intolerance which is diagnosed during pregnancy. Now, it is usually observed in women having a strong family history of type 2 diabetes mellitus, or more it is found amongst women who have a higher BMI, that is those who are overweight and obese. And apart from these two, advancing age, then excessive weight gain during pregnancy are also some of the causes. And also gestational diabetes during former pregnancy also increases the chances, previous stillbirths or having given birth to a child with congenital abnormality are some of the factors which puts a woman at a higher risk to suffer from gestational diabetes mellitus. Now, for this, pregnant women are usually tested for gestational diabetes in the second trimester of pregnancy. Maternal hyperglycemia can be detrimental for the mother as well as for the fetus also, because it increases the risks of miscarriages, stillbirths, congenital abnormalities, macrosomia as well as other obstetric complications. Even though gestational diabetes is a temporary condition, why we are calling it a temporary condition is that after the woman gives birth to the baby, after that the gestational diabetes would vanish. That means the woman would no longer be having hyperglycemia. That is the reason we are saying it is a temporary condition and normoglycemia may set in post delivery. However, there is an increased risk for women who have suffered from gestational diabetes to suffer from overt diabetes with advancing age. That means as they age, there are higher risks or higher chances for a woman who had gestational diabetes to suffer from diabetes at a later date. Also, the other thing is that children who are born to a mother with gestational diabetes, they have a higher risk of being overweight or obese. They have a higher risk to suffer from diabetes and hypertension during their whole lifespan. Means it increases the chances of the siblings as well. Now, in treating women with this condition, it has been advocated to minimize the fluctuations in the blood glucose concentrations in order to avert maternal hyperglycemia and thus decrease the risk of fetal hyperglycemia and its consequences, as well as fetal hyperinsulinemia and excess fetal growth. However, despite early diagnosis and aggressive dietary as well as insulin therapy, perinatal morbidity among the infants born to women with GDM, that is gestational diabetes, remains excessive, a fact that may or may not be attributed to suboptimal glycemic control. Now, with regards to the management of gestational diabetes, various methods of glucose monitoring have been proposed, including the measurements of fasting blood sugars, preprandial, postprandial and mean 24-hour blood glucose concentrations. With respect to diet therapy, which should be the first line of defense in the treatment of women who are suffering from gestational diabetes. Now, women who failed diet not only require more intensive medical management, but are often offered increased fetal surveillance, which adds substantial cost to treatment. Hence, the dietary modification that should be done in case of gestational diabetes would be consumption of carbohydrates that are digested more slowly and attenuate postprandial hyperglycemia might be a favorable approach to diet therapy in case of gestational diabetes mellitus that avoids the need for carbohydrate restriction. That means one should be eating foods which are rich in fiber, etc. Now, studies have shown that women who consume a lower glycemic index foods, means lower glycemic index foods when we are saying, means that they are those foods which do not result in a spike in the blood sugar levels immediately upon consumption. So, as I mentioned that studies have shown that women who consume a lower glycemic index foods, they have been found to require less insulin in comparison to those who consume higher glycemic index foods. So, diet therapy for women with gestational diabetes has historically, if you see, it has focused on carbohydrate restriction, but evidence from randomized controlled trials, however, has shown or it supports the idea that women with gestational diabetes, they tolerate higher complex carbohydrate diets. So, that means they are able to tolerate higher complex carbohydrate diets. In fact, the data from randomized controlled trials would suggest that a diet which liberalizes complex carbohydrates, that means using higher fiber or what we say is lower glycemic index carbohydrates, for example, and a diet that limits saturated fats may be optimal in improving glycemia and also preventing further insulin resistance and also attenuating excess fetal fat accretion. So, larger, however, in this case larger, highly controlled, randomized prospective trials are gravely needed in order to identify the optimal diets that would be helpful in case of gestational diabetic women. Hence, to summarize this module, we have seen in this module, we have studied about various pregnancy related complications. Some of them were the very common ones like nausea, vomiting, etc. Then pregnancy induced hypertension, gestational diabetes, anemia, etc. And also we studied about the dietary modifications for the same in order to be able to prevent, or we can say to reduce maybe the symptoms. So, it can be symptomatic relief what we are saying, or and or it would be basically trying to basically see to it that detrimental outcomes do not come out of that. So, that is what we have been able to study today in this particular module. Thank you.